The UNCOPE is another one that has a similar format. So for the UNCOPE, in the past year, have you drank or used drugs more than you meant to? Have you ever neglected your responsibilities? Have you ever felt you needed to cut down? Has anyone objected to your drinking or drug use? Has your friend or family or anyone else told you they objected? Have you ever found yourself preoccupied? Have you ever used alcohol to relieve emotional discomfort? And the 2 or more positives suggest abuse, 4 or more suggest abuse or dependence. And as we talked about in the past module, abuse and dependence has been changed in the DSM-5 to different levels of substance use disorder. So here are some other types of screening tools that are all indicated in Tip 42. There are more than these, so if you are interested, please feel free to take a look at that chapter. Circumstances, Motivation, and Readiness Scale, or called CMR, is designed to predict retention and treatment and is applicable in residential and outpatient. The DAST, or Drug Abuse Screening Test, to identify substance use and has a quantitative index regarding the degree of the problem. The LOCUS, or Level of Care Utilization System, assesses immediate service needs, plan resource needs over time, assesses service requirements, and monitors change in status. The Readiness to Change questionnaire is for adults and adolescents. It assesses readiness to change substance use behavior. And the SATS, or Substance Abuse Treatment Scale, which assesses and monitors state of treatment and progress toward recovery. So a screening protocol, it involves a professionally designed screening process or protocol which establishes precisely how many screening tools or questions are scored, what constitutes scoring positive for a particular problem, like establishing cutoff scores, and what happens if a client scores in the positive range. We talked about that a minute ago. So it's just as important as having a screening protocol is determining what happens when someone scores positive. And also provides the standard forms to document results of later assessments and that each staff member has carried out his or her responsibility in the process. So you will want to know, if you see a positive screening, how do you know that the appropriate protocol was in place for making sure that person was connected to services? So screening is a process for evaluating the possible presence of a particular problem. So you're going to be screening to see how likely is it that something is present versus how likely is it not to be present. And one question to consider with your organization when identifying a tool and a cutoff score is, what is your sensitivity to false positives versus false negatives? A false positive means you have detected a potential condition that does not exist. So someone comes in, they complete a screening tool, you have said you are likely to be an alcohol, someone who has an alcohol problem, when the reality is that person doesn't have an alcohol problem. So based upon the questions and how it's scored, that would be a false positive. It says that it is an issue when in fact it's not an issue. On the flip side, you want to ask yourself the sensitivity to false negatives. It does not detect a condition that does exist. So the person responds to the questions appropriately. They do in fact have an alcohol problem. Based upon their scores, it misses them. It says they don't have a problem. So when you're selecting tools, you may want to ask yourself, how comfortable am I that some people might fall through the cracks, or I might over-identify people who don't have the condition at all? Because, and sometimes it's helpful to look at your staffing as well, because you're never going to have a tool that's perfect. So you might find that having false positives, so you say, okay, you have 50% of the people that you screen don't end up having the problem once they're assessed. That you might feel more comfortable over assessing or providing some additional assessment items to try to sort that out a little bit, as opposed to people falling through the cracks. Or it might be, you might go the flip side and say, I know some people will fall through the cracks. I'll probably catch up with them at some other time because they'll probably, come up with some issues in treatment that will identify them as having this issue. So I'm not as worried about having a screening test that will be, I'm not as concerned about sensitivity to false negatives. So assessment is a process for defining the nature of that problem and developing treatment recommendations for addressing it. A comprehensive assessment serves as the basis for an individualized treatment plan. The treatment plan must be matched to individuals' needs. So it's important that there's this thread between screening, assessment, and treatment planning, and then the treatment interventions. So you wouldn't want to do an assessment and identify 5 needs and then have treatment plans that only address 2 needs consistently in your organization. Because if your assessment is identifying 5 different types of needs and your treatment only addresses 2, how do you establish goals to help people get progress on those other 3 needs? So I think this is kind of a no-brainer. So screening for co-occurring disorders seeks to answer yes or no. Does the person with substance use show a sign of possible mental health, or does a mental health client show signs of possible substance use? So some other areas that you may want to screen for include safety risk, past and present mental health symptoms and disorders, and substance abuse disorders, cognitive and learning deficits, and then past and present victimization and trauma. Screening for substance use disorder in a mental health setting. Some of the screening some of the screening protocols that may happen in a mental health setting could include substance abuse symptom checklists. So it could be that the person in their personal history form are checking off some items that apply to them or that they've experienced. It could be substance abuse severity checklists, so that you can determine how severe is the condition. Formal screening tools that work around denial, so how do you determine whether or not the person is being upfront with you when they're completing the tools. And it can also include screening of urine, saliva, or hair samples to get a better idea of what types of substances may be in that person's system. Okay. So we covered 1 through 3. So we just wrapped up the screening process for co-occurring disorders. Let's talk about the step 4 and 5. 4 is determining the quadrant and locus of responsibility, and 5 is determining the level of care. Now, this is distinct, and it's sometimes easy for people to confuse the two. So let's start with 4 and talk about the 4-quadrant model and the locus of responsibility in treatment. This is figure 2.1 from the TIP manual. This is the level of care quadrant model. We'll talk a little bit more about this, and we'll actually utilize an example or a case study as we walk through this. So we're just going to do a very quick review, and we'll dig into it a little bit more as we go. If you look at the far bottom left, you see a circle that says low severity. Category 1 is low severity of mental illness and low severity of alcohol and other drug use. So this is someone who is low on both conditions. The locus of care for this type of low individual can typically happen within a primary health care setting. This is not necessarily someone who will come into a substance abuse provider location. It's also not necessarily someone who will be seen in a CMH system because their behavioral health needs are low, their substance use needs are low. They might be treated in primary health care, they might be treated at a federally qualified health center. They can typically get any of their lower level needs met in those areas within the primary health care setting. If you move over to the bottom right box, which is category 2, this is high severity mental illness, low severity alcohol and drug abuse. So this is someone who actually has higher level needs for mental health. The locus of care for this population tends to be the mental health system. So they would be seen in the mental health system. They may have some needs that occur in the substance abuse system, but it would ideally be handled within the mental health system because it's a lower level need. And if you notice the arrow, this represents that it's actually a continuum. So it's not just SPMI and no substance use. I mean, there will be a range, but it's the lower end of substance use and the moderate to higher end of mental health or mental illness. If you go to the upper left box, which says category 3, this is low need in mental health, moderate and high severity in substance use. The locus of care for this quadrant is typically the substance abuse provider system. So the person has some higher level needs for substance use treatment. They get it in the substance abuse provider network, but they might have some very low needs for mental health issues as well. But that ideally is managed within the context of a substance abuse provider system. Finally, category 4, which is the upper right box, is moderate and high severity of mental health issues and moderate and high severity of substance use issues. This is the population that could most benefit from integrated care and a very seamless, integrated treatment that makes sure that it's wrapped around this person and that they have an integrated care plan that addresses all of their needs. These are the individuals that may end up in state hospitals, in jails and prisons, and in emergency rooms. So you want to make sure that they're receiving the proper care and that there are providers out there that can address this higher need population on both ends. So one question that you may want to ask and be aware of is what is the state's criteria for serious and mental illness? How is eligibility established? Is the client already receiving mental health priority services? And does the client appear to be eligible? So in order to make sure people don't fall through the cracks, having a good solid awareness of what services does this person qualify for, even if they're services you don't provide, is very important. So here's an example. And this case comes right from the TIP manual, so you can go and refer to it later. This is Maria M. The client is a 38-year-old Hispanic Latina woman who is the mother of 2 teenagers. Maria presents with an 11-year history of cocaine dependence, a 2-year history of opioid dependence, and a history of trauma related to a long-standing abusive relationship which has now been over for 6 years. She is not currently in an intimate relationship, and there is no indication that she's at risk of self-harm or violence. She also has a persistent major depression and panic treated with antidepressants. She is very motivated to receive treatment. So that's Maria. So let's talk about Maria and talk about and walk through how you might determine the quadrants of care for her. Remember, category 1 is low severity substance abuse, low severity mental illness. Maria would fall in this category if her substance use was mild and her mental illness was not severe. Given the example, I mean, obviously the example didn't contain a lot of information, but given the example, it doesn't feel like she falls in category 1. She actually has a pretty significant history of substance use and has some significant mental health needs. If she did fall within 1, she could probably be managed in primary care. Category 2 is low severity substance abuse, high severity mental illness. She would fall in this category if her substance abuse was mild and her mental illness was severe. Given the case example, she probably doesn't fall here either. If she did, she could be managed within a mental health setting suited to meet her mild substance use needs, which her substance use needs seemed a little bit more severe than category 2.